your network for advanced risk models. And this is a really hot topic right now, and we're really excited to hear from these guys today. So I'm glad you joined us. A few items of note before we get started. All attendees have joined today in listen-only mode, so you don't have to worry about muting your mic. That has been done for you. And don't worry, we're not seeing your camera either, so you're okay. And I'd like to let you know that the webinar is being recorded, so you'll have the opportunity to rewatch the session afterwards and or share it with colleagues, and we hope that you do. This is something that we want you to be able to come back and reference as needed. And I will be sending out a link to the recording as well as the slides to download after the fact, so keep an eye out for an email from me afterwards. And finally, during the webinar, we want to hear from you. So please reach out, please ask questions. You'll be able to submit questions to either of our presenters or both using your attendee control panel. And there's a little picture of it up here on the screen so that you can ask questions there. And these questions are also being recorded. So even if we're not able to get to yours today, we're going to make sure to follow up via email afterwards. So don't worry. So go ahead and ask your question, even if we're pushing time to up to the very end, and you don't have to wait till the Q&A in order to do it. Go ahead and just submit your question whenever you would like. Okay, without further ado, I want to introduce very briefly our presenters. Today we have with us Rebecca Molesworth, who is the VP of Product Management with Trella Health, as well as Mimi Freelo, who is a solution engineer with Trella Health. So I believe Rebecca is getting us started, so I'll hand it over at this time. Welcome, Rebecca.
Thank you. We're excited to be here. We've been looking forward to this webinar for a long time. So today we thought we'd start with just a little bit about what Trella Health is and what we do here, and then we'll go right into our content. So Trella Health, we really focus on transparency in a market-wide, visible way for our clients. We create consistent and standardized quality and cost measures at the physician level to allow our clients to build, optimize, and explore new network opportunities. And one of the ways we do that is by using our innovator's license with CMS. So we have access to the chronic condition warehouse at CMS, which means we have 100% of the Part A, Part B, and the ACO providers and beneficiaries across the entire Medicare fee-for-service beneficiary base. We also have 100% of MA claims all the way through 2018. We have about 75% of the 2020 MA commercial claims for over 65. So all in all, we're holding about 90% of the 65 plus lives in the country. And what that allows us to do, we're going to talk a little bit in the subsequent slides. We have other data sets we're looking at in the future, but that's just a little bit about us and where we are and what we do in the market today. So about our agenda. So today we're going to talk about modeling your network for ACOs and for GPDCs. We're still getting used to the change in the acronym, probably are too. But we're going to start with the key considerations that we think you should think about as you're building out a network. We're going to dig into evaluating the market. We're going to talk about building optimal PCP rosters. We're going to dig into specialists, and finally looking at how do you make sure that you have a really broad market that will actually include the whole set of providers that are influencing your patient care, including post-acute. We'll talk a little bit about appropriate care settings, and we're also going to talk about the ongoing network management that we feel that organizations need to do in order to be truly successful. And then we're going to open up to you guys, and we'd love to hear your thoughts, your experiences, and any questions you might have. So with that, I think most of the folks on this call have been involved in an ACO or a DCE in some way, and well aware that there's so many things that you have to consider when you're starting to build one of these business models out. I have a list of some of the things here, whether it be just trying to understand the model itself, if you're using one of the CMS programs, creating a leadership model, creating a clinical and an IT support model that will manage the care of the patients, defining your clinical strategies, and somewhere in all of that, you have to build a comprehensive network as well. And so what we want to focus on today is how do you make sure that you're not missing a critical opportunity while you're building out that provider network. So because the concept of lowest hanging fruit, and there's 3 items here over on the left hand side, and I call them lowest hanging fruit not in a pejorative way at all. They drive huge cost. They tend to be, when we talk to folks who are in ACOs or thinking about becoming a DC, they really focus on inpatient readmissions, makes sense, huge cost driver, ED utilization, and then SNF utilization. And that's, it's a very acute focus, huge dollar amounts. It's also where patients tend to jump into the system through the ED, the quick, easy button of getting care fast. So it's absolutely right that people spend a lot of time there. The one thing that we're learning, though, is as the ACOs mature, as the DCs go on in their maturity level, we're going to see them start to look at higher hanging fruit, if you will. Things like, do you have the right PCP mix? Not just that you have PCPs, but are they the right risk of acuity and the right risk of practice patterns so that you can develop an optimal network? Do you have adequate specialty coverage? Are you using a full preferred provider network that includes post-acute in that equation? And even beyond that, are you looking to the community network, social workers, social economic focus on how patients are being cared for out in the community once they've left the acute setting? And then also making sure that the care settings are appropriate, that they're getting the best quality care they can in the lowest cost setting. The way you manage this higher hanging fruit is definitely impacted by your business strategy. It also has the risk of increasing your acute costs if you're not managing it well. And it also is more difficult to work through the transitions of care. As you get further away from the acute setting, it seems harder and harder to keep track of the patients. They go back out into the regular life, and patients have less ease of access into some of those solutions or providers as compared to an ED. So it's higher hanging. As maturation occurs, we tend to see ACOs and DCs start to focus more and more on that. And so we want to talk a little bit about pathways to a successful network. We've seen a couple of different models. A lot of the early ACOs had no choice, and so a lot of their networks were relationship driven. They were based on, who do I know in the existing network that we have? They'd reach out to the local physician community and look for in their catchment area for relationships they could extend into a risk-bearing relationship. Or they'd look and see who's been practicing in the area or already has capitation experience and try to find those folks. But it had to be without data and very much about relating to the physicians and building relationship. That's still true, but there's also much more data available now to actually do a data-driven investigation of the network you're in, and being able to evaluate existing physician performance and their behaviors, evaluate the costs and outcomes, and do comparisons to local and state benchmarks. So you're starting to look at how does this provider perform compared to everybody else around them. And you've seen a lot of data sources being used, certainly clinical sources, evaluating EMRs, asking for basically a chart review of physicians to see how they're performing and how they're coding. We've seen folks go to the CCLF data, the CMS data for their attributed or likely attributed population, depending on where they are in their life cycle, looking for specific beneficiaries and looking at their claims to see how that's being impacting their network. And then with organizations like Trella, we have market data that allows us to look across the entire Medicare Advantage and fee-for-service network. It's de-identified to our users, but it gives you a broad spectrum on how those benchmarks could be impacting your savings. So, and the reason this matters is that without something that is broad, where you can see the whole market, you kind of get lost in your own echo chamber sometimes. And there's the data that you have around the beneficiaries, the members that are attributed to you based on your physicians, but you don't know about things like, what are those providers doing with their fee-for-service populations? How many of those people are they seeing? I mean, do they have 50 people in your ACO, but there's 250 sitting out there in his patient panel that you don't have attributed to your ACO, and you're looking for ways to grow. Other ACO behaviors and other networks, so you can look and see how are the ACOs on the other side of town doing this, given the same regional challenges, or way across the country, how are they managing populations that are similar to mine? You can start to look and compare across all the different active ACOs in the market. And you can also find providers that aren't in an ACO. So one of the difficulties of being only able to see your attributed population and the providers that they're seeing, you can't tell who's sitting right next to you down the street who might be a really high value physician who could be a part of your network. And that's not to say that the other data sets aren't important, because of course they are. CCLF, is great for deep view of a longitudinal view of a patient and where they've been in the system. But again, it's only for the beneficiary population that you have had attributed to you, and you don't know who's coming next or who's leaving. It can also cause you to miss high value physicians that aren't in a DCE or an ACO right now. They might be out there and fantastic for your network, and you won't be able to see them in the data itself. And it doesn't allow you to make comparisons to other ACOs. I think there are some reports that give you benchmarks and things that you can use at a high level, but being able to really drill down into what are your ED rates like versus my ED rates is not something that the data will allow you to do. EMR, great for timely management of patients. You have to have that kind of data if you can get it, because it tells you exactly where your patients are and what they're doing in that moment. But you, again, don't get the broad view of the total population and what their utilization is like. You're missing those fee-for-service comparisons. So, you know, are your patients really sicker than everyone else's? And you're missing adjudicated cost data in that data set. And so looking across the full market at what people are paying for services and what is normal, what is average, and what you're paying can be very different and can vary highly. So reasons to think more broadly than just the data you have in-house. And I'm about to hand it over to Mimi, but before I do, just quickly, you know, we're going to talk about why we think a comprehensive network strategy is really important, and it needs to include all of the partners in the ecosystem. It involves being able to understand the market that you're in and being able to see what everyone around you is doing, being able then to select primary care providers who are going to drive the best value for your strategy, being able to add then in the specialists that are being selected not only based on their quality and their cost, but actually that they match the characteristics of the population so that you have the right number of specialists of the right kind in order to support the needs of your population. Skilled nursing, have to know, you know, what's going to happen, especially with the 3-day waiver. Can you use skilled nursing strategically in order to manage lower ED costs while taking on more costs in skilled nursing, as opposed to inpatient admits and things like that? And then finally, how do we keep patients who can stay home, where we know certainly from COVID that they are safer there. They most likely would rather be there. And there's lots of ways to bring care into the home in order to support those patients in a lower cost setting in a place that they will naturally do better with things like home health, private duty, hospice, even hospital at home. I'm hearing more about SNF at home. There's a new focus on how do we manage the cost of care in each setting. So with that, I'm going to hand it over to Mimi, and she's going to drill down into more of the gritty details of the kinds of measurements that we're using and helping our clients use in understanding their network opportunities. So Mimi, why don't you take it away?
All right, thank you. So when you're first starting to, the first step, I guess, and when you're really wanting to set up your program, you know, it's really doing a solid market evaluation. We've broken it out into 4 different steps or categories just to keep it simple. But the first, when you're just evaluating what market should we even open up a ACO or a DCE program, it's first understanding the competition. What is that competitive landscape of the current ACOs and other direct contracting entities in that market? Who are their PCPs that are on their roster and their preferred physicians that they are using within the ACO, and getting visibility into that. And then understanding who are, we'll call them free PCPs that are available. They're not part of an ACO today that you can more so easily recruit for your program than convincing somebody to potentially leave their current ACO. And then understanding with the competitive landscape, what is that beneficiary penetration that they have today? So looking at how many eligible Medicare patients are there for attribution or, you know, alignment, and how many do they have? What does their churn look like? So how many patients are going in and out of the program? And starting to see, is it because it's more competing and going to other ACOs, or just patients are dropping out, they're not seeing their PCP, whatever it might be, or they're moving, anything that can go into the churn aspect of it, and getting visibility into just how are other ACOs and direct contracting entities in this market performing? Are they successful? Are they not? Is it going to be highly competitive, or is it going to be there's still room for us to grow and add in, and we know that we can come in and do a really good job and earn that shared savings? Then the second piece is the PCP assessment. So there's been a couple things that are really big into evaluating the market. With the PCP, is there going to be enough PCPs in the area to cover the population? So we kind of refer to this as a PCP desert. Sometimes there's some pockets in the US that have a ton of fee-for-service beneficiaries and not as many PCPs to cover them. So the current PCPs are already completely full of schedule, like their schedule's full. They might be a little less likely to join potentially. And just knowing that before you go into it, to know what your potential obstacles are and what your area of opportunity might be. And then with the PCPs in that area, what is also the fee-for-service versus the MA population breakout? What does that demographic look like? Is this heavy fee-for-service? Has it been trending to Medicare Advantage? And then the PCPs that you would like to target, you know, what is the opportunity for you to potentially negotiate contracts like MA contracts for them? So then you could look at other upside potential business in addition to your program. And then looking at, you know, which PCPs are available for roster and how many eligible Medicare patients would be attributed to them. So like looking at that claims-based alignment, this is something you cannot get in your CCLF files, is knowing PCPs that are not in your market, like in your roster today, knowing how many beneficiaries they would actually bring. A lot of times we've heard our clients are just, they look at the total amount of fee-for-service patients they saw. They typically say, okay, usually maybe 20 to 30% would get attributed, and they're making guesstimates. And that's something that, you know, we could provide visibility in showing exactly, you know, approximately how many patients would be aligned to you through the claims-based methodology for each program. And then also looking at how many patients are eligible for alignment, meaning they're not aligned to a PCP today. So what's also the potential alignment and growth with those PCPs? Next, looking at the beneficiary characteristics. So just looking at the analysis of the patient and their needs within that population that you're looking at, and understanding the overall, what's the historical spend versus the MA rate book. Like, is this something, is there even an opportunity to improve? Is it going to be kind of a, I don't want to say easier win, but just knowing what is it today and is it, how much potential do we have on reducing cost and generating a shared savings? And then looking at the breakout of each spend category. So understanding utilization patterns, like what is driving up the cost, like what makes up the cost, and getting just that first picture of, is this something that we could improve on? And then lastly, resources in the market. This is something I've stood up a couple different programs, and it's been interesting. There's the specialist market. Are there enough specialists to treat the patient characteristics? Two, the hospital market. You know, if all the hospitals in the area are at a 90% plus census, you know, just know that they might be harder to get discounts on and stuff like that when you're negotiating contracts. Just knowing what you're getting into before you actually say, let's do it here, and spend all that time that it takes to start up the program. And then lastly, just more like community support things that make your life easier instead of having to do everything single thing. If there's Meals on Wheels in that area, if there's like the Uber driving to appointment services, there's as I'm from Southern California, so I don't understand sometimes, like, you know, that there's just areas where Uber's not even around. You know, finding that out has been interesting to see. And so making sure patients can get to their appointments, and then also the social workers in the area. Is this something that we'd have to completely start from scratch, like building this type of program, or are there other resources that can make it quicker and easier to go to market? Rebecca, next slide. So diving in deeper to the optimal PCP roster and the components that we typically like to look at when you're looking to target PCPs and looking to model out that network. So PCPs are really the core of value-based programs, and identifying PCPs that align with your goals is really key for success. The first kind of step is really, targeting physicians. So really discovering what physicians would bring the highest alignment of patients and with a historical benchmark that would set your organization up for success. This is something you really can't know, like what I mentioned earlier with the guesstimating how many potential aligned patients they could bring. You don't really know if that's actually going to be the amount. So really getting a complete picture of who would be aligned and how many would be aligned to those physicians. So it's really about focusing your time and, focus your time on the physicians that would bring 500 to 1,000 patients versus, going in blind and only getting 50 aligned patients per doc. We see it all the time, and it's about the same amount of workload effort to bring a doctor on board. So let's maximize the value of each one that you try to recruit. And then looking at the risk score. So if you look down below in the lower part of the slide, these are just some examples with the targeting that we've seen very useful and it's like a common theme between our clients of what they like to look at when they're building their roster. And with the risk score, it's, what are the chronic conditions and the comorbidities of their aligned beneficiaries, and what are the resources that they might need. Then looking at historical spend and the breakout by spend category. So knowing where are costs going today, what are they referring out for, like especially the PCP, is this something that the PCP could have done instead of the specialist they referred to as a potential cost saver? And what does that look like? So is it more going to be a physician behavior, which, as you know, can be a little bit more challenging than having your resources come in that could help them with identifying the risk score and, coding. Those are things that are usually your program can do, but changing the physician's behavior on how what he prescribes and directs his patients to do is something that kind of takes a whole different approach, and potentially partnering them with other physicians in your network that do well. Let them be the example and let them learn from that. And another piece of all of this is, especially with the spend, is comparing physicians, when you want to look at them side by side, making sure that you're using risk-adjusted cost and quality metrics. No two patients the same. So when I say risk, I'm talking about acuity risk. And so making sure that you're really selecting the right doctor for those looking at the right doctor, just because he has a super low risk score and his costs are low might not mean much, potentially. Then looking at the per member per year base cost. So of the aligned beneficiaries, how much on average for that entire year did that PCP get reimbursed for their aligned beneficiaries? So especially for the direct contracting program where you're going to be negotiating rates with the physician, a lot of our DCE clients can see how much are they making today. So then they can say, look, we'll pay you more than what you're making today per patient. And we'll take a lot of the administrative burden off of you if you come join us. It's really knowing that type of information before you even go into the meeting so you can recruit that physician to join your program. I'll talk about that a little more on the recruit piece there. Then another metric that our groups typically love to look at is the ACO participation. So are they in an ACO today? And, would you have to convince them to leave their ACO to join your program? Or also, what is their experience with ACOs in the past? Just knowing that talk track, so it looks like you know the doctor a little bit more than just going in blind. And you can use all of these data points to actually, create a compelling message, knowing what to talk to them about. when you try to recruit with them. And then the MA lives. How many MA lives are they seeing today? And so you can understand what is their experience level with risk-based models, and also what is the opportunity for you to grow their MA contracts, and looking at that piece so you can get some clarity into other potential opportunity areas. And then lastly, with each physician, just understanding the physician-to-physician referral patterns. You know, who are they using today, and is that specialist good at controlling unnecessary spend? Just to get that first visibility with building that. So then the next step is building your roster. So you've now kind of looked at these different metrics. You're selecting which ones you think would be good. Like, I want to target this one, I want to go after this one. But now it's like putting it all together in your program and modeling out the selected physicians to understand what is the projected benchmark, and, you know, how does that compare to the historical spend? You know, is this setting you up like for success, maybe a potential, I don't want to say automatic win, but, you know, getting you closer. And so it's a lot more manageable to generate shared savings. And then what does this group of physicians look like together for the program you're starting? Does this group make sense? How many, you know, where do all the beneficiaries reside? Making sure that it's aligned with your goals and what you're trying to accomplish, and no outliers are there. And then the last thing that's really important with looking at all the physicians together that you're wanting to model out is making sure you're meeting those program minimums. You know, do you have the minimum amount of patients that's required for the program to even start it? Of course, our goal is to make sure you're well above the minimums, but you know, that's been some feedback we've heard from some groups that have started the DCE program this year, is that they were a little shocked at I guess not the restrictions, but how, even though they thought they had some aligned, just certain things with like the high needs program and stuff like that. So really interesting to see that, but just want to make sure that you're meeting those minimums when you have that group together. And then lastly, or the third part, is recruiting. This is something I feel like is very under talked about, maybe. It's really, you know, every physician is different. And I really feel like it's like creating a pitch to the doctor. It's kind of like a sales process where it's, you know, your pitch should be different for every doctor you talk to. Make it about them. That's what's going to make them want to join. So analyze that data beforehand and create a compelling story from that data as to why they need to use you, like why they should actually join your program. And it's that if you don't join us, you're losing out type of feeling, and getting them to switch. So really just taking it to the next level instead of waiting for physician groups to knock on your door and then you evaluate if you want to add them. It's let's go after these high value doctors and make sure that we get them first before they go to anyone else, and knowing what to talk to them about. And then with some other things that you know that you could help them with, so you can see if, like, for example, when you're going in to meet with them, if their risk score is lower potentially compared to their peers. You know, it could be a lack of coding experience and they might need help with that, and you know that that's something that you do, as well as just understanding what is their revenue for the practice, what is the patient volume at that practice, how many nurse practitioners and PAs, and then how much preventative medicine. So you can just get an idea of what this doctor's doing, so it looks like you're coming in prepared for this meeting. And then lastly, optimize. Can't stress this enough. You just really should never just set it and forget it. Really stay on top of the market, and always are constantly coming back and looking throughout, even after your program has started, because the market can change, regulations change, and this might affect your program and your patient alignment. And then minimizing churn, really getting visibility into the patients that you are aligned to now, and that other outside docs might be seeing them a little bit more. Also, if there are potentially other changes that might affect churn that you're unaware with just your CCLF files. And then ensuring that you do have the best docs for your program, and also continuously looking for growth opportunities and new physicians in the market that would add more patients to your program, and that would help your benchmark. All right, next slide. So with your specialist network, so PCP, you've got your core now, like you got your team going out and looking, recruiting those doctors. And then the next real big step is looking at your specialist. One, taking those population needs of your aligned beneficiaries that you're anticipating having aligned to your program, and ensuring that, based on the patient's risk and conditions of the population, that you have specialists to support those, especially with, there's, all these things that can go into play with their population needs, but like social determinants of health, what is their average age, like the age breakout of each aligned patient, the number of dual eligible patients. So knowing kind of what that looks like in the structure will help you understand what needs that you should potentially be looking at when you're growing and using your specialist network. Dual eligibles is big as far as like the, potentially the patient. A lot of times we've seen that the patient is less likely to do some necessary follow-up items because it might be too hard for them to get to the appointments, or the cost of medicine might be too expensive, like stuff like that. So, are there other treatment options and other doctors that provide those treatment options that might have a better outcome for this actual cohort? We know that this other is the best of the best, but they're less likely to do it. So this is actually the best for that particular cohort of patients. And then looking at the coverage area of these specialists. So where are their clinic locations, and where do most of their beneficiaries reside? Could you potentially grow this relationship and acquire new aligned lives through your specialist? So seeing who refers to that specialist, and also are those PCPs in an ACO or DCE program today? Then cost and utilization. So this is really big. So looking at the episode-based cost and utilization of the specialist. So, diving in, you can dive in a little deeper, but understanding what is, their operation to patient ratio. Are they higher than their peers for the same episode type? So getting visibility into who would be the best for that particular need that you're trying to fulfill of your patients. And then evaluating common anti-patterns in the physician's behavior. So for example, interventional cardiologist, how well are they managing the patient medically? Are they prescribing anticoagulants as a treatment first, or do they just jump in and start opening up the heart on the patient? Understanding that type of detail is going to be important for you to know on who you should partner with. We have plenty other examples, but a few come to mind. Just dermatologists, taking more surface area than needed for a Mohs surgery. Pieces like that start to really add up and can affect your can affect your shared savings in the end. And then lastly, with the cost and utilization, another big one is, where are they performing surgeries, and are they using a hospital for ASD eligible surgeries? That's a big, potential cost driver as well, is their location of services provided. And then lastly, with the quality, are their patients more likely to get readmitted, or do they require hospitalization due to complications, and that's what's driving up their cost? What's their mortality rate? And different, but still making sure that their patients are happy with them and their satisfaction scores are high. Go to the next slide. All right, so I feel like building your post-acute networks, it's it's been an interesting pulse on the market. Some feel very strongly about, I don't want to do that, and they just want to focus on their PCPs. And then some do see this. And I feel like something I personally just have seen in the industry is because what I've typically seen when you build your post-acute networks, they're just looking at basic stuff like star ratings. And I feel like if you really want to build a smart post-acute network, you really need to go way beyond that. And some of the first couple things, excuse me. So for each of these, like home health, hospice, and SNF, understanding first just the volume of patients that they're receiving in their average daily census. Is this something that they could even handle your patient volumes of potential referrals that you would be sending to them? And what's the average risk score of their patients? What's the type of patients that they're seeing that they're treating, and where do they do well? So you can actually start to see, like, by patient cohort and by like diagnostic category, and also DRG level, and acuity level, you know, how are they doing on those types of patients, and making sure, so now you know your cohort of patients. Let's go look at, filter out to that particular type of cohort and see who are the best home health, hospice, and SNF agencies that match with your patient population. That's now the type of building your post-acute network that we focus on, and it's building just a really, I like to call this a smarter post-acute network, instead of just looking at some of the basics that doesn't really show if they're good at what you potentially need. So a couple metrics that love to look at is just understanding how sick their patients are, what's their average length of stay at each place, and then their total cost of care. So what we do is we look at not only just the cost of care at that during the home health stay and just for that home health, but we also look at what was the downstream impact of their services. You know, what was their quality and cost? So you can see, were their patients more likely to go back to the hospital, and that drove up cost? Did they set the patient up for success? That's when you're actually using post-acute to your advantage and making sure that, one, we're sending them to the appropriate care setting, and then two, the places that we're sending them to they're actually making the patients healthier and better, and less likely to go back to other unnecessary services based on their great care that they're giving. So just two other, just couple different metrics to look at that kind of go into play with all of that is, you know, looking at their readmission rate, also their 30, 60, 90 hospitalization rate after their stay. So this is after they left their home health or SNF. What did the hospitalization look like? And actually with hospice too, you hopefully, if a hospice is a really good hospice, you know, the patient should not be going back to, well, mostly should not be going back to the hospital after they've started hospice care. So what's actually happening there? And some key pieces to evaluating that is just how many visits is that home health agency doing on the patient? What type of visits are they doing? Are they doing a lot of nurse therapy, you know, social work, whatever type of visits that they can provide, and getting visibility into how well are they actually taking care of the patient? How often are they seeing them? And that could be another reason why, if they're not seeing them as often, they could have gone back to the hospital because no one was there taking care of them. And then lastly, just the mortality rate. So evaluating, making sure, like, if there's a huge mortality rate for SNF, home health, you know, looking at, could this have been, you know, should we have probably looked at an appropriate level of care, like potentially hospice instead of these other two areas? Or was it actually, you know, the cause of death was actually due to a complication of their services? Really distinguishing between the two. So with that, I will go back over to you, Rebecca.
All right, thank you. Yeah, so in looking at all those different metrics, you know, there's there's a lot to explore as you're expanding your network and thinking about who you want to interact with and who's going to help you with your goals of your organization of you know, the triple aim, the quadruple aim. One thing that we've hearing a lot about lately that I think is really interesting is losing the idea that just reducing cost is the answer. And I think, you know, this is true across many different modalities and practices, but you know, making sure that you've examined your available options around care settings and understanding what care settings are going to drive the optimal success. So, you know, are you taking advantage of hospital at home? Is that starting to evolve? And I know that's a moving target at the moment, but as that starts to come to fruition, are you thinking about how you could use that? Or what's here now today, the SNF 3-day waiver, having folks go right to the SNF rather than having to have these observation days. Can you use skilled and unskilled home care to support that patient if they're coming out of the discharge from a hospital and you know it's going to take 3 days for home health to get there? Is it possible to bring in unskilled labor just to make sure that that person is taking their medications, that they're able to do their ADLs and their ADLs appropriately? And then, you know, looking at hospice appropriate care, and I know it's a difficult subject, but when using hospice appropriately, it does have major impact on cost, but also on quality of life for the patients. And this is not an exercise in cost avoidance alone as you're looking at these care settings. You know, it was true in the old days of disease management. You expected some costs to go up while other costs went down. I think the truth is we'll find the same thing is true here. You know, are you able to avoid costly inpatient ED settings by using post-acute care more appropriately? Are you able to find procedures and services that are lower cost options? You know, we all like to talk about the generic drugs, about, you know, alternative Part B drugs, but there are procedures too that could potentially be done in a less costly way and drive the same amount of value. And then managing transitions of care, and this gets hard. And I know that, you know, population health has been discussing this for, you know, a good decade at least. But, you know, how quickly can you get to the patients and get them what they need in terms of the transition to the environment they'll do best in? And how do you find that lowest cost care in the most high quality setting that you can to deliver the outcomes you need? And helping patients avoid the easy button. You know, the hospice example, you know, those who are not using palliative care soon enough, the I'm in so much pain, I need to use the ED, could be avoided if you're managing those transitions of care appropriately, and that will reduce cost. And then finally, predicting those who are going to fall through the cracks. I mean, I'm sure we all have stories of times where a loved one was not able to get the care they needed in the time they needed in the way they needed. So how do we start to become more proactive in predicting those who are going to have a different need for a different kind of care setting or a different kind of care? And then how do you use the data to then determine anti-patterns in the patient flow? So if you know you're sending people from the hospital, they're going to a particular SNF in your network, and the amount of rebound rate is pretty high, you're seeing them coming back into the ED, there's a pattern that there's probably something to look into, and it's probably driving up your costs. So just some things to think about in terms of not just thinking about getting costs down, but actually having costs be in the appropriate place. And then finally, want to talk just a little bit about the ongoing management of a network, and then we have a little poll we'd like to do, and we'll open up for questions. But, you know, as Mimi said earlier, it's not set it and forget it. You know, actively managing your preferred partners is important. We spoke to an ACO earlier in last summer, actually, that was they had in their first year, I think, 80 different SNFs they had partnered with. And I think it was really just you know, any comer was part of their preferred network. And in that second year, they learned the hard way that it didn't help them with their savings or their management of the network. So they ended up going down to 15 in the second year and trying to then manage and really partner with those agencies so that they are on the same page about how the patients need to be managed, how to make sure that everyone's getting the best possible care. As Mimi mentioned before, keeping a pulse on the market is critical. If you don't understand the changes that are going or they come past you, obviously that can have an impact on the success of your business model. And reducing patient churn. I think the last number I heard was 20% of patients were churning in the MSSP ACOs on average, and that's a lot of change. Making sure you're recruiting new PCPs and specialists as you're seeing new players come into your market area. How do you start to engage them and bring them into the fold so that you have more partners and more growth in your ACO or your DC? And then looking at modeling the changes so you can maximize share savings. There's a lot of opportunity in just looking at the data and understanding how the behaviors in the market are impacting your cost and as well as your benchmark.
And Rebecca, one thing I'd like to add to that. So really looking back at the actively managing preferred partners, I've heard a lot of times, well, we can see how they're performing through our CCLF files. When I can actually go and look and see, okay, well, how many patients, you know, was that compared to their total population? And we're talking about maybe maximum 5%. So you're just getting a sliver of visibility into how that post-acute is actually performing. And you only know for your patients, well, what if you know that you found out that they do much better with sepsis and you haven't sent any of your sepsis patients there? So getting that type of visibility into the market and then using standardized data to manage those partners is key. You know, having a regular meeting, having a standard set of data that comes from one source is imperative, I think, to keep them, you know, aligned and make sure they have the same goals and not getting distracted.
I think it's a really good point, and sharing that data with the physicians, because as you know, these are very bright people who have lots of experience with data, and I think they like data when they can get it and help them understand how they fit into the broader business model is probably something they would value. So with that, I'm going to flip this over to a poll, and I think Garrett, if you're able to launch a poll for it. We have 2 questions we'd like to ask you guys. Let me see. Garrett, I'm not seeing how you can.
Okay, I'm sorry. So hey everybody. So the poll should be up on the screen now. And Rebecca, do you want me just to read the question, or do you have it in front of you?
Go ahead. Yeah, go ahead, read it.
Okay, sure. So the poll is this: what data sources do you use to evaluate / build your network? And you can select all that apply here. And let's see, the first is your CCLF claims from CMS, clinical EMR data / ADTs, social determinant of health data sources, or SDOH sources, all Medicare patients data, VRDC and QE, and then CMS PUF files.
PUF files, yes, the public use files.
PUF files.
Yeah. Thanks, Garrett. I did want to make sure you get the word in right.
We're given a second here for the, it's collecting responses. We'll give it about 10 more seconds and then we will move on. Were there any of those, Rebecca, that you wanted to clarify or touch in on specifically?
Well, I'd love to see if we can see the results from the first poll.
Yeah, let me see if I can.
People are doing.
All right, so I'm going to close this now. Looks like everything's come in, and let me see if it'll allow me to share the results. Let's see here. Here we go. And Rebecca, you may not be able to see this on your end, but
unfortunately, yeah.
Yeah, she's using one screen over there, folks. So looks like we have 78% came in as CCLF claims from CMS.
Makes sense.
67% is clinical EMR data and ADTs. Only 11% is social determinant of health data sources. And then all Medicare patients data, VRDC and QEs, that is 22%. And then the CMS PUF files is 22%. So by far the highest was the CCLF.
Yeah, and that isn't far off from what I would expect to see, because that's really valuable data. It's interesting, 20% of you were able to look across broader market data, whether it be a PUF file or finding a partner who's using the VRDC or the QE status with CMS in order to have access to a broader set of data. I think that's probably pretty consistent with what we're seeing in the market. So I think those who are using those broader data sets, and I won't lie and say we're the only vendor who provides them. There are a handful out there that do. They have a leg up because they have got access to all the data and they're understanding how the market's playing. So thank you guys for that. We appreciate that. We were curious to know how much of the secret was out, but there it is. Why don't we launch that second question then? And this one is just asking if you're interested in knowing more about our ACO and DC network building programs. We'd be happy to follow up with you. If you do not feel bad. But if you say yes, that means somebody will follow up with you and see if you'd like to learn more about some of the work we're doing.
Okay, we'll give this about 5 more seconds.
Cool. And you don't need to share those results. We'll just keep those.
That's okay. Yeah, sure. Okay, although I will say there's a lot of folks here that did, so so very good.
Yeah, that's exciting. We get really excited about the topic. We obviously like to dig around and learn more, but now we get to go to my favorite part, which is where we get to open the floor up to you guys and see if you have any questions or any comments, experiences you wanted to share. We take comments too. And Garrett, I'll let you help us get that started.
Sure. Okay. So, and yes, we do have a lot of questions that came in, which is great. In full transparency, we do, with all of these, we have a few seed questions that we'll put in there, but there is no need for that today because we had a lot of interest in just coming in from you guys. So let's get started in no particular order. First of all, is how does an ACO know the optimal mix of PCPs and SCPs?
I think I'll start, and maybe you can be more specific and detailed, but I think that it depends on your business strategy. And in working with different groups, we've seen lots of different strategies deployed. So there's no one right way to do it. It's one of the things that makes working in this space really exciting, is because every time a client comes to us with a new strategy, it means a new way of looking at the data. I would say there are some that are going after really, really high risk. They're trying to push their benchmark up really high so that they have a lot of opportunity to earn savings by changing behavior patterns or other types of patterns. We've seen others that are looking for experienced physicians who already know how to work in a capitated model, such as an MA physician practice or something to work with, because these folks already understand value-based care in and of itself. And so those are just a couple of examples. I think there's probably as many examples as folks we've talked to. And Mimi, I don't know if you want to add any more specifics in your experience of what you're seeing. And obviously we don't want to give away any trade secrets of our clients, but just some of the variability in the strategies we see.
I'm afraid if I share what I know, it might be sharing some trade secrets. So I'll keep a mouth shut right now. Good answer.
Call us and we'd be happy to talk more about things we've seen, but it's a great question. And I think that's some of the secret sauce in actually managing the business of having an ACO or a DC model. When I first started working in ACOs, I always thought it was just, this is a better way to take care of patients. We need the right clinical strategies. We need to be able to manage the patients through the population, through the transitions of care, all the way through, population health. And that is all very true. I think in working here, this is the other side of that equation, which is, how do you manage the business? And it really is a business. And that's as you've watched the early successes and failures of all of these folks who are taking on this risk, it's real, right? So we can certainly talk more offline about that if you'd like.
Yeah, very good. A little teaser. Yeah, definitely reach out to them to find out more. Okay, the next question here is, what have you found to be the best specific data sources to evaluate the potential value of adding an identified open PCP to your roster or for your roster?
I can take that one if you want.
Yeah, go for it.
So honestly, to me, there is really only a very specific answer, and it is a data vendor that has either the VRDC or QE access, which is Virtual Research Data Center, and qualified entity with CMS. So these are a limited number of entities that actually contract with Medicare, and Medicare allows them to get 100% of all the data. But so you 100% need to make sure they have that. And then the second piece is you got to make sure that they are actually running the metrics that look at the attribution. So being that data source, all that means is that you get access to the data and it's all raw data files and claims. But you need the vendor to be able to run the attribution methodology based on the program that you're trying to build. And so those are really two key pieces. And then making sure that the attribution, because this is going to be something proprietary to each one, is accurate. It's really imperative. And that's something that we've worked very closely with our clients to make sure that like we are spot on. We're using the same exact methodology that CMS publishes, where it looks at certain specialists, it looks at their claims that count towards attributions, like the CPT codes that count, and running it off the exact same model that they've published. But do know that not everyone cannot be 100% perfect because of voluntary alignment. So voluntary alignment would be the only thing that you have no control over. You don't know where your, if a patient is going to go to the CMS website. We do feel like that's really low. So it shouldn't be that far off, but just to clarify.
Yeah, that voluntary alignment is actually a good thing to talk about, just because it's definitely playing into strategies that these organizations are doing. I mean, I heard recently in a conference, someone who was saying we only do voluntary alignment. That's it. You have to come and join our practice, our world. We're not, and others who are not relying on it at all. And so it's definitely a mixed bag. And then with the DC program, you can do a paper voluntary alignment. You don't have to get the patient to go to a website, which is what I believe you have to do for the MSSP program, which is really hard. It puts a barrier to entry on that.
Yeah, and it's really interesting to see the ones that say, oh, if you rely on voluntary alignment, like you're gonna fail. It's a wide range. And I think it does also depend on the program too that you're trying to start up. Not just the DCE or ACO, but actually what type of direct contracting program versus a high needs versus a standard new entrant. What does that look like?
Great. Well, let's keep moving on here because we do have a couple more, and then unfortunately we got to wrap because we're running up on time. So the next question is, and I'll kind of ask it in two parts. The first part of it is, what have you found with respect to different strategies between rural and urban ACO locations?
That we should talk about that's the physician and the patient density. This is a slightly aside, but I was just reading Health Affairs. There was an article in Health Affairs about one of the biggest causes of churn from MA back to fee-for-service is the rural network. And so it's definitely a challenge. I have heard some of the ACO DCE folks we've been talking to say that, they're staying out of the rural areas just because it's hard to match the patient density with the physicians. I think there are probably some though that'll lean into that. And so I'm not, again, like all of this, there isn't really one best practice. I think it's what levers can you pull and how can you manipulate the different levers of what's specific to your region that you're looking at that's going to make the difference. And I don't mean that to be a non-answer, but I don't think there's a perfect answer to that question.
Yeah, and to add to that, sometimes there's just like there might be specialists in the rural areas, but if not, it is looking at, potentially some transportation services that could be free for the patient. That would be more likely for them to go to a specialist, 30 minutes away, because if you're going to ask them to drive that long, that could be a potential barrier, which we found out that is usually the number one barrier is, them being so far away from their home. And so having that type of the Uber piece to it, or another type of transportation services that could pick them up and take them to their appointments, or that somebody that could come to their home, it usually helps with the rural side.
Awesome. And then we are really close to out of time. This is such an important second part to this question that I just have to ask it so as quickly as you can answer it. What have you found a difference in the receptivity of your strategy assessments and recommendations between hospital-led and physician-led ACOs?
That's a really good question. I think what I would say is that I've seen more difference between, I would say, like the MSSP program and the DC program. Myself personally, I mean, you should answer for yourself, but in terms of the new program allows more parameters around being able to aggressively pursue different tactics. And so the strategies are you have a lot more levers to pull on the DC program than you do in the MSSP program. And that's by design, right? That was the how to on-ramp into value-based care. DC, you can kind of like go all out. So you have a lot more you can do. So I would say the strategies are more aggressive on the side of DC that I've seen.
And I've actually definitely seen a difference between hospital based ACOs and physician-led ACOs. Complete difference. I'm trying to think of the easiest way to answer this. I feel like hospitals are less, like, that's just one piece. So sometimes they really have like a harder time focusing primarily on that. And also they're used to this whole fee for service world in the hospital. The more patients they get, the better their revenue is. So it is a little bit changing that mindset. And I just have definitely seen a difference when the strategy of implementation between the two. And to me, I'm not saying one's right or wrong. This is just for the ones I've worked with personally, but the PCP-led ones have been more innovative in certain ways. Like I'm not giving too much away, but yeah.
Very cool. Well, unfortunately, that is all the time we have, and we went over just a little bit, but it was worth it because it's just such a great presentation. But as we close out here, I wanted to encourage everyone here to visit the ACO Exhibit Hall booth for Trella Health, which is on the screen here, and you can get access that by going to ACO Exhibit Hall. Then you'll see them on there in the exhibit halls back there. And it's a great way to interact with their team and learn more about what they're doing. And it's very cool. You can kind of see what they're up to, and there's a lot of great resources that you can see at the acoexhibithall.com as well. And then lastly, just wanted to thank you all for coming. If you wanted to reach out directly to either Rebecca or Mimi or anyone at the Trella Health team, please feel free to reach out. Their contact information is here on the screen. So with that, thank you again so much for coming. Thank you, Rebecca and Mimi, for a wonderful presentation. I hope you all found this very informative and helpful as I did. So have a great rest of your day and stay safe and stay healthy. Thank you for coming.